Welcome to Module 1, Addressing Diabetes Risk Factors in Elementary School-Aged Children. On behalf of the National School-Based Health Alliance, we're excited you are with us. We are offering CME/CE credits for this session. There will also be a post-webinar survey shared in the chat at the end of the webinar. We do not currently have any disclosures. You will get a copy of these slides in your thank you email as well. At the School-Based Health Alliance, we believe that all children and adolescents deserve to thrive, but too many struggle because they lack equitable access to healthcare services. School-based healthcare is the solution, bringing healthcare to where students already spend the majority of their time, in school. When schools, families, students, and the community work together, students win. Today's team, we have Shamika Davis, our program manager at the School-Based Alliance. Myself, Jenny Altieri, I'm the administrative assistant on this project. Paula Fields, our vice president of programs and technical assistance, as well as our speaker, Jessica Wallace, from the Family Medicine PA and director of the Healthy World programs. Just a quick reminder, all attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during the webinar, please use the Q&A tool located in your Zoom control bar. We'll address questions as possible during the webinar. If we do not get to your questions, please feel free to email us. If you would like to add your comments through the chat function, please select all panelists and attendees before sending the message so everyone can see it. At the end of this webinar, attendees will be asked to complete an evaluation poll. Please let us know how we're doing. Your feedback is vital in helping us craft presentations that meet your needs. We plan to share some resources and are super excited to have Jessica Wallace from the Denver Health with us. She will share about their related work soon. So let's get started. I will now hand off to my colleague, Paula Fields, for our objectives.
Thank you, Jenny. Today, we're going to talk a little bit about why addressing diabetes risk factors in elementary school-age children is important, especially noting the significant exacerbations during COVID. We will then transition over to hearing about evidence-based strategies in Denver Health's work to put those actions and hopes that you can identify and recognize some of these strategies, both in your existing work, but also take away ideas that you can trial and that you think will work in your community as you look to move your work forward. So with that, why is preventing diabetes risk factors in elementary school-age children so important? And you'll see on the screen that these charts from the U.S. Preventative Services Task Force notes that about 3.7 million children and adolescents are obese and about 5.6 are severely obese. And Jenny, if you will go to the one more slide, please. And between 2001 and 17, another JAMA publication noted that the estimated prevalence of type 2 diabetes increased among children and adolescents. And so again, the why, we are all here to focus on work around detecting early indicators in hopes to reduce and eliminate those type 2 diabetics and the complications from type 2 diabetes and comorbidities and that excess mortality. We want strong and healthy children. So when you go to the next slide, we just want to show you the research of the burden of obesity in children and adolescents that find that strong association of possible comorbidities. Also includes mental health and psychological issues, obstructive sleep apnea, orthopedic problems, and cardiovascular and metabolic issues, including high blood pressure and insulin resistance. When you ask someone who has had firsthand experience about obesity coupled with the research, you'll note that negative stereotyping is common, and children and adolescents report teasing and bullying behaviors based on their weight. So with all that said, we move on to add in the COVID pandemic on top of those staggering numbers. And you'll see that COVID just catapulted our obesity rates in the 6 to 11-year-old range. In 2018 to 20, those identified as overweight obese or BMI more than doubled during the pandemic. And 6 to 11-year-olds experienced the largest increase in the rate of BMI, about 2.5 times the pre-pandemic rate. So those are quite significant and a really timely topic as we look at what we're all here to talk about today. Because, before 1990, type 2 diabetes was nearly unknown in children. And today that incident in people under 20 is expected to triple by 2050. So school-age children and adolescents represent a growing proportion of potential diabetic patients and where we can really make a lot of difference. I'm not going to dive into all the deep statistics on the screen, but know that they're there. If you need them from reference, when Jenny sends the PowerPoint out afterwards, you'll have those. So why is preventing diabetes risk factors in elementary school-age children important? I think we've kind of hit on those. It's increasing in need, and we want to prevent or ameliorate any of those outcomes. The national recommendation is to complete a BMI or body mass index screening annually with nutrition and physical activity counseling. The definitions are similar across different bodies of national performance measures, such as the CMS, Center for Medicare and Medicaid, the UDS, HEDIS, and even for school-based health centers. If you didn't know, we're excited to have some school-based health centers with us today, but no worries if you don't. We'll just start with some ideas of where your work is. And a little bit of history. About 5 years ago, there was no national set of performance measures for school-based health centers. And through HRSA funding, we were charged with developing a set of national performance measures. Many of you may be familiar with these, but we started with a long list. And based on feedback from those of you in the field, they were narrowed down to 5. And you might ask what that national quality work is, and the answer is simple. It's what it makes possible for students. That annual well care visit represents the highest standard of quality preventative care, and BMI is a component of the diabetes prevention that we're talking about today. It can happen at a well care visit or independently. And all these measures really help us learn more about students and identify where we have the best chance of prevention or to minimize adverse outcomes. All of these have one thing in common, and each measure just directly correlates to supporting student success. What's at the center of the work we all do. If you'd like to know more, you can visit our website. And on the next slide, we gave you a glimpse of one of the toolkits or playbooks that's packed full of ideas that's been shared from your peers. And like I said, even if you're not a school-based health center, you can look at these and see if there's ideas that resonate or spark in your area of work to try on. So the last thing I have to share with you is what I'm most excited about, and I'm super excited to shift to what addressing diabetes risk factors in elementary school-age children looks like in action. We're excited to have Jessica Wallace from Denver Health with us. She holds a master's in public health, a multi-specialty healthcare, and also is a physician assistant, a certified physician assistant in family medicine and director of Healthy World program. I think it's all yours.
Awesome. Thank you. It's really great to see so many people joining us. Let me get my slides going. Can you hear me okay? Great. All right. So I'm going to move into our experience that we've had at Denver Health over the last few years now. I would say that our primary goal in my organization, I'm sure as you all can attest, is really to use the evidence as the roadmap for what we're going to do and what we should be doing and what's right for patients. Those guidelines are actually quite robust. This is a slide from the CDC, but if basically shows all of the different evidence-based strategies that exist for prevention and treatment. There's a lot of different guidelines that feed up into this. Those are kind of the boxes at the bottom. Don't worry about memorizing this. It's just to kind of show a framework that there is a lot that can be done and kind of how we at Denver Health have looked internally to build that up. It's important to note that the American Academy of Pediatrics guidelines are from 2007, but they're actually just about to release new guidelines later in 2022. So that's really exciting. The first thing that we do at Denver Health that is of utmost importance and obviously relates to the measures that we have to track, and you all are doing as well, is that BMI screening at the individual patient level. And, just like you all do, we view it not just as a point in time, but also as a way to evaluate changing trajectories over time, and highlight potential risks and opportunities. What this screening doesn't do is tell us how to have that conversation. And also, I think what's become more and more evident to us at Denver Health over time is the role of weight bias and stigma. A lot of that data has started from adult research and advocacy, health at every size movements and things like that, but really kind of tailoring it to what does this mean for kids in our system. There are additional screening tools that are recommended. So certainly the nutrition and physical activity screening, most commonly known and utilized are probably versions of 5210 or 521010. This in our clinic is sometimes a handout that families fill out before their well child check, or some other form of kind of automating it into the EMR. This will ultimately reduce time that you all have to spend, because it helps direct individualized counseling. If you find out that kids are not drinking sugary beverages, then you don't have to waste time going over sodas and juices. So it can be a time saver to really making it personalized. Also, screening for social determinants of health. I think this is a new area that we at Denver Health have been trying to move into. It doesn't mean that we have answers for all of these factors at play, but food insecurity in particular is one that's gotten a little bit more traction, and probably for you all as well. It's when a lot of communities do have resources such as food banks, or kind of a patchwork of nonprofits and churches and things that will do kind of direct food donations and distribution. So it is helpful to screen for social determinants and try and connect patients to resources when we have them. Family history, we're establishing for kind of everyone, regardless of their BMI in the moment. Comorbidities, that gets into things like lab screening and stuff, which is super complicated, I know, but we'll discuss that a little bit more later. And behavioral health needs, and when you find things like social determinant needs or behavioral health needs, if you're lucky enough working in an FQHC or school-based health center, a lot of times we do have additional resources to offer. So what we're going to do with these polls is not necessarily, have to review every single one individually, but this is a chance for you all to hear kind of what your clinics and health centers might be doing. So what screening tools does your health center currently use? And so we'll take a minute just to see what folks have to share. Couple more seconds if you haven't written anything in yet. Want to offer up your experience? Cool. Okay. Is there a way to show answers that have come in, even briefly?
I think I can only pull the report afterwards. Or
Okay. All right. Sorry about that, guys. We did get good answers. We'll make sure that we have those around so that you all can see kind of what is going on in your area. And I want to bring it back now to those evidence-based strategies and kind of how we've taken it from there. One tool that we've been trying to increase training and kind of support for in our clinic is around how to have that conversation and utilizing the tool of motivational interviewing. I'm sure lots of you have been exposed to this in various ways. I used to be kind of, talk down about motivational interviewing. It seemed like, this thing that tried to make it way too, something complicated, way too formulaic. I've come around because the really good tools that support motivational interviewing can help and really help you get through even where you get stuck with patients, or once you've tried it out a little bit more and you've seen if it goes well or what doesn't go well. AAP supports some of those, changetalk.org. They're really great to look into. So definitely, if you're interested, do a deep dive into motivational interviewing training and CME. The general steps involve kind of that initial engagement. And this can be something like, is it okay to talk about your weight today? Is it okay to talk about your son's weight today? And really getting permission to make sure that it's an okay time before we just, have our own agendas. Really using the conversation and questions as a guide and kind of jointly finding a focus around where the issues are. Again, if you're doing this in the context of that individual patient visit, you've already gotten some data around the screening. But this is another chance for families to really share their experience and where they are right now. And then you use that conversation and that connection to help them think through what internal forces are at play and where they want to focus their energies, which ultimately leads to a plan. The idea is to have a strategy where you work together and that feels meaningful and possible for patients. So, the other thing that comes from the evidence-based strategies is really something that occurs outside of the individual patient visit. U.S. Preventive Services Task Force, this is their primary recommendation, which is an intensive lifestyle based behavioral intervention. And there's all sorts of different ways you can do this, but at the end of the day, what matters most is how long you work with patients and how many touches you have. The magic number seems to be 26 or more contact hours, and it just gets stronger the way you go up from there. Most of them are dealing with kids who are in that elementary school age or a little bit older, but there's 40 plus years of data that show that these interventions are what are most likely to make a difference for our patients. And I'll take a strengths-based approach here, and I'll say that in primary care and in the relationships that we have with our patients and families over time, both in community health centers and school-based health centers, actually sets us up a lot better than other community organizations who might be trying to build and then sustain a relationship. These are our patients, and we do have these long-term relationships over time. So yes, it's kind of intimidating to think through how it can be done, but we're going to deep dive a little bit into that more. Important to note that USPSTF has also been giving more space to the role of pharmacotherapy in weight loss. And, I think this is an area that we'll kind of continue to expand upon. Again, kind of outside of the purvey of what we're talking about today, but I do want to acknowledge that, especially when we continue to deal with, an individual patient in front of us, medications can play a role in some circumstances. So next question for you all is, does your health center currently have some sort of intensive intervention? Could be like a diabetes prevention program or a lifestyle change program for your kiddos. And while you're responding to that, in the chat, I do see the results from the poll, which is awesome, and lots of good stuff in there that really aligns with the evidence-based strategies. So great work. Give it a couple more seconds here. Yes, no, maybe, not quite sure. Cool. Okay. Since that one's just a click. All right. So we're going to move on and then we'll see what we found. I think it's important to kind of, before I deep dive into what we've been doing as an intensive intervention within Denver Health, to give a little bit more context about Denver Health. Maybe you'll look at this and say, well, gosh, that's just totally different from my organization, doesn't relate, or maybe you'll see some similarity. So we are a safety net healthcare system. We actually do have a safety net hospital affiliated with us, but in the outpatient world that I work in, it's a network of now 11 11 FQHCs, and now we're at 19 school-based health centers. But we take care of patients regardless of the ability to pay, and we see up to 1 in 3 Denver kids. This is a CDC map. It's actually looking at 2019 adult data, but I think it's super compelling, one, because Colorado looks like one of those lone holdout kind of, green healthy states. And that's definitely the perspective, right? Is that Colorado is fairly healthy, especially compared to other states. And I don't deny that that's true, but I would say that, when I moved from the East Coast to Colorado about 9 years ago, I was shocked, right? That everything looked exactly the same as the clinic I worked at in the East Coast. And, this relates to poverty, it relates to minoritized communities, and so you can have, just like in any of these states, you can have a very, very different experience in terms of risk and, depending on who you are. And so CDC has also started collecting this data by, I think, federal poverty, percent of federal poverty level, and also racial and ethnic minorities, to kind of see how different this experience can be. And so I definitely recommend checking those out. Most of us have looked at these maps before and have seen kind of the transition over time where they keep adding all of these new colors because the prevalence of excess weight is going up so much. And I read a cool quote one time that really resonated with me that said, it is highly implausible that this pronounced trend, which is now being replicated in countries around the world, is simply the result of millions of independent, unconnected decisions. And the point there is that you don't have this kind of profound change over time in a population just because people are making bad choices. There really is something larger at play. And I have a feeling I'm preaching to the choir about this, and definitely COVID made it worse. You saw the national data. That's definitely our experience at Denver Health too. So the chart on the left looks at the percent of kids at a healthy weight. And for our kids in January 2020, we were about 60% of kids who had healthy weight. Nothing to write home about, but what we saw by September of 2021 was that we had dropped below 55%. And that kind of drop over here, you can see on the graph, we've never seen anything like that before. And it took a while to really know how bad it was because we lost touch with kids, at least in person, with well-child checks where we could see their weight. But as those kids started coming back in, it became very clear what we were dealing with. And all that to reinforce both the CDC maps and this kind of our experience with COVID is, as you all see every day, this is a problem that is more than just the individual. And this is the classic kind of socio-ecological model and all the different ways and levers that impact health and well-being. And, even all the way up to the societal level, like a global pandemic that completely disrupted daily lives. And yet, with that excess weight and with that kind of changing trajectory over time, tremendous pressure and burden on kids and their growing bodies. Diabetes, of course, is a focus, but it is quite broad. And some of those play out quickly and in the present moment, and others are more that kind of will plague them in the future. So we take it seriously. We also did a little bit of digging into our patients. And, at that point in time, we had 22,000 kids who had excess weight, BMI over 85th percentile. Again, that prevalence is similar to what you'd see just about anywhere, similar or worse. We did a look back of kids who had been referred to our grant program when it first started. And out of those, we weren't screening everyone the way we should have. But out of the ones that we were screening, we found 50% who had qualified as prediabetes with that elevated A1C. And that was a huge wake-up call for us of just how much was happening that we weren't even aware about. We also saw elevated cholesterol, elevated ALT, and elevated blood pressure. These numbers have shifted over time, and that's kind of its own interesting story. But regardless, these kids are sick, and it doesn't manifest in the same way that's in front of you, like a fever would, or like some of the other stuff we see. But this is the risk of chronic disease, is how long it exists silently without intervention. So I want to acknowledge here some really important data that obesity is not a one-to-one correlate with disease. A lot of this data comes from the adults, but it's important to recognize. So on the side to the left, if you look at adults who have an elevated BMI, 2 out of 3 have metabolic abnormalities. What that means, though, is that this tiny little piece of the pie, 33%, have elevated BMI and are metabolically normal, what's now being called kind of metabolically healthy obesity, or MHO. Alternatively, if you look on the right-hand side, if you look at adults with a normal BMI, fully 1 in 3 have metabolic abnormalities. So what the heck do we do with this? At the very least, it tells us that if we use elevated BMI as, a gatekeeper for who gets what additional intervention, education, support, we're not hitting all the right people. And so it's important to keep that in mind. There was another fascinating study that came out years ago, again, looking at adults, but it was using NHANES data. So you could get a large data set and pretty diverse throughout the US. And the graph shows you basically the first thing to look at is that the darker bars correspond with a higher BMI. And what you're seeing here on the bottom are the number of healthy habits that you participate in. And so when we're talking about healthy habits, there are 4 that they looked at. Do you eat 5 fruits and vegetables a day? When you actually look at the number of people do it, it's like 10% or something. Do you exercise regularly? Do you drink alcohol in moderation? Do you not smoke? And so when they look at BMI compared to habits, what they found is that in this first column here, if you do none of those healthy habits, your BMI really matters. And that elevated BMI is a huge risk for increased mortality. But if you go all the way over here to the right, if you do all 4 of these healthy habits, it doesn't matter if you're overweight or obese. It makes essentially no difference on your risk of excess mortality. So again, weight matters, but underlying healthy habits or unhealthy behaviors matter a lot. And so that being said, there is evidence to show that working on excess weight can have an impact on disease as well. So a lot of this data comes from the Diabetes Prevention Program, which was created through the CDC. It's been around since 2010. It's looking at those adults with prediabetes, which, similar to the data we see with kids, most have absolutely no idea. And what they've found over time is that for participants who lost 5 to 7% of their body weight, so just to kind of put a number to it, if you weigh 200 pounds and you lost 10 pounds, you were 58% less likely to develop diabetes. So there is clearly something here that warrants making those behavior changes and looking at weight as a factor. So I think the takeaway we had from all of this kind of messiness is this is not about a diet. It's not about, some sort of rigid, you must weigh this thing, especially when you're looking at kids. It's more about healthy, happy, good behaviors that you can kind of create and then build and continue over your lifetime. And that's where we created, as a team, a global aim statement. So we have kind of an umbrella of programs called Healthy World. And we were very deliberate about making sure that we weren't just viewed as a diet or a weight loss program. Our goal is to support patients in making lifestyle choices that help them manage chronic medical conditions, improve the quality of their life, and reduce their health risks by mindfully enjoying delicious and healthy food, moving their bodies in ways that make them happy, and improving their self-confidence, happiness, and well-being. And, if you haven't had the chance to kind of do that, kind of visionary work, even in a very small team, it can be so motivating and provide, that course correction too, even as you go along when you find out, it help enforce kind of the changes you're making. So, transitioning back to some of that evidence-based strategy. So the AAP guidelines put it in as this kind of staged intervention. And, they made it in a graph. I view it more as like an upside down pyramid, where, the stage 1 is something that is really does matter and should be available for most kids when they need it. And this is the follow-up, individual support, the weight, the nutrition and physical activity counseling, right? But you go up from there depending on what people need. At the time when we started all of this, we live in Denver, which is great and does have a children's hospital that pulls from the entire region. So, we basically either had visits with the PCP or we referred them to our children's hospital. And go figure, not many kids would go. There was always issues with insurance, with transportation, with travel, with satisfaction, with barriers in terms of hours. So it was really, there was this huge gap, and we felt that kind of day in and day out. And so what we did was we looked at that kind of second stage of the structured weight management, which is really overlaps quite closely with what the USPSTF tells us, which is that intensive behavioral intervention. So we got a grant, and we got a grant through, I think the first one we got was through the Colorado Kaiser, which has a community benefits grant program. And, those exist for a lot of nonprofit hospitals. And so we got a tiny grant, and we decided to pilot an intensive behavioral intervention in our clinic. We chose MEND. MEND stands for Mind, Exercise, Nutrition, Do It. And the reason why we chose it, I do want to talk through a little bit about that. Anyone can partner with MEND, you got to pay for it. But it is a family-centered intensive intervention. Adults and kids meet in a group twice a week for 10 weeks. So it's a significant commitment. For the first hour, there's kind of like this education and support kind of program. And then the second hour, the kids go and do exercise, and the parents have a more in-depth discussion. So, the structure makes sense and checks all the boxes of what the guidelines say works. It's very out of the box. So if you do get a little bit of money, it can help reduce the barriers to getting started. You have all the tools in there that you need to recruit, to teach the curriculum, to incentivize, and stuff like that. There's cool little teaching tools, again, just to really reduce the barriers. You train your staff. There was a randomized controlled trial, which obviously is our gold standard for evidence. This was published in the journal Obesity in 2010. And basically they found that kids had improvements in BMI, improvements in waist circumference over time compared to control groups, and also sustained as far out as 12 months, which is not shown here on this graph. This bottom left graph of exercise recovery heart rate improved when it goes down. That's an improvement in their physical fitness. So that was, really awesome to see. And importantly, self-esteem went up. So, we're not causing any harm by focusing on, doing a deep dive in this program. And then, RCTs, sometimes the challenge is how do you translate that into the real world, especially our patient populations within health centers. And so they did that. They took that program from the UK and they kind of disseminated into community settings in the United States, and they, patients mirrored ours. A lot of families with, public health insurance, underinsured, low socioeconomic status, and they still found improvement. So, when we had the little grant and my organization was like, let's not reinvent the wheel, MEND became something that was easy for us to implement. So we brought it into our clinics. We knew there was this huge gap between what we could do kind of one-on-one versus the kind of support, families needed and were asking for that they weren't getting necessarily at our tertiary care center. These are the first 3 clinics that piloted it. I will say you can easily try and do this in a school-based health center as well. So it's not meant to only be implemented in one setting versus another. For the first couple years, again, we had a grant, so we followed kind of the protocol about all the things to measure. And all that showed was, yes, we could bring MEND into our clinics. We didn't have a gym. We didn't have exercise instructors running around with whistles and stuff, but it still worked. And that was really powerful for us to say, okay, this is worthwhile to keep going. We don't measure all these things nearly as robustly anymore because we don't have to. We proved it worked, and it was kind of burdensome, as anyone who's implemented a grant knows. We didn't, it was too much to keep going with all of that. The significant adaptation we made that helped us move from a grant-based program into something that's been sustained long-term now is the integration of provider medical visits, what we call MEND Plus. And for any of you out there who've done any group visit models, we use the Centering Pregnancy model through the Centering Healthcare Institute. And our goal here was really to improve that individual evaluation and management, right? We had seen the kind of significant comorbidities at play that we didn't even know were there. And these were kids that were now coming in twice a week into our clinics for these frequent touches, but we didn't connect it so deliberately back to their health. And there are just some issues that come up in the families that aren't appropriately addressed in a group setting. So by adding on that additional layer, not only were we able to bill for some of those visits and then use that to convince our organization that we could help offset some of the costs of running the program, but again, we could, really tailor how we were able to help our kiddos. So because we were now in the EMR, the magic, horrible EMR, we did have a way to measure in a different way our impact. So instead of having to do all of the crazy surveys and all that stuff, we could just take a cohort of the kids that have participated in MEND in any given time over a couple years and say what happened. And this is a super messy graph, but this did just get published in academic pediatrics. And basically kids before they started in MEND, their weight was going up and their systolic and diastolic blood pressures were going up. And there was they modeled it out and it was a certain amount by month over time. So kids were on that upward trajectory. And then what they showed is even with the first MEND visit, but also sustained over time when they were done, that trajectory changed. Again, for both the BMI percentile as well as systolic and diastolic blood pressure. We were able to look at controls of all the other kids who could have qualified for MEND, but didn't ever get referred or come, and it was statistically significant. So that was really exciting to say we were on to something here. Diabetes risk did not get evaluated that rigorously because we weren't screening everyone for diabetes. Some kids, it wasn't indicated. Some kids didn't want it. And if you're trying to convince a kid to come to a fun, intensive program, some kids really, if you had to say oh, we have to do a blood test first, they'd be like, mm-mm. So, we just fit it in however we could. We screened some. There definitely was a significant number of kids who came back abnormal. Out of those kids who came back abnormal, plenty of them never got checked again, an area of improvement in QI that we can work on. But from the kiddos that we did know over the couple of years, it did seem like there was some significant improvement that could happen in some of the kids, not all the kids, but just to tie it back to those diabetes risk factors. Then in kind of 2019, 2020, I started working on a grant through the National Association of Community Health Centers. And our goal here was to work with other FQHCs throughout the country, looking at taking these intensive models and bringing them in-house. So called COMMIT, Childhood Obesity Management Models in Team Setting. And these are the different states that we've been working in. And again, the idea here is to take the evidence and what we know works, and then kind of use the power of FQHCs to kind of provide those local level adaptations and innovations that work for your patient population. And so when you do that kind of translational stuff, you want to ensure fidelity. And so for any of you out here, who are like, oh, MEND sounds really cool, or, something like this, could I create something like this? I say yes. And, just the things to keep in mind are what works. So for example, MEND program, like you saw, is twice a week. I had done a similar kind of curriculum when I worked in Washington, D.C., and it was once a week, and we did it for years. And I was like, when I came to Denver and we got this grant, I was like, there is no way families are going to come twice a week. And I was surprised. For some families it didn't work, but for those who it did, they made it happen. And so, you do really have to be deliberate. It doesn't mean you have to do a twice a week program, but you can't change that dose or those touches because you're going to dilute how much you can actually help families. So get creative about how that fits, but keep it intensive. You want to keep all the components, right? The best programs and the guidelines say you got to have nutrition and physical activity, parents and kids, and you got to have that kind of support. But that being said, you don't have to talk about, sugars and salt and fats in the exact way that a MEND curriculum talks about it, or a Cooking Matters curriculum talks about it, or Bright Bodies. You can make it work for you and measure to make sure that you're not losing track of does it work over time. then COVID happened. And that really changed everything for these programs. So I'd be disingenuous if it didn't acknowledge that and say, what the heck have we been doing for the last 2 years? Initially, it just shut down everything, right? It wasn't safe to get our families who are highly at risk in person. That meant that a lot of programs that were ongoing, from one day to the next, they no longer had that connection and that work. So early days, it was a lot of individual outreach and touching base. And then, when we kind of dawned on us that this was going to go on, we started building out our curriculum in a virtual capacity. And that's been something that we've kind of continued to adapt over time. So it means taking the topics and make them into PowerPoint slides and, coming up with the right platform and, figuring out how to get kids and keep kids engaged. Obviously we weren't doing physical activity, so this was its own thing, but there's a lot of cool resources online, and we would, pick videos and everybody would, turn on their camera and we would dance and play. And especially in the early days when there was a lot of social isolation, when there was a lot of kids just stuck at home and we didn't quite have all of the Zoom fatigue, people really liked having that connection and that opportunity. It's changed 7 billion times since then, but it is possible. And so even during COVID, we tried to ensure fidelity, but we just tweaked it a little bit. So nutrition education, we went from being in a group and being able to be very dynamic and break up into groups and play games into now you're staring at a screen. And so we added on cooking demonstrations. We got a $5,000 grant. And we, did these little cooking demonstrations, and we would, have families pick up a bag with the ingredients for the recipe, take it home, and then everybody's cooking together once a month. Behavior change, obviously, like the burden just exploded. So we connected with some of our behavioral health folks at the clinics and kind of integrated them in where they could kind of teach little sections of the curriculum, and they could outreach to families who needed help. So, doing our level best. And so that takes me to another poll. Hearing our experience of how COVID has disrupted our example of an intensive intervention, how has COVID affected your health center's ability to help support your patients and families in their healthy goals? And we'll give this one a little bit more time because this is a little complicated. And I'm looking at the results of the other poll, the second poll. 26% of you do have some sort of intensive intervention or lifestyle change program. 52% of you know, unsure, 22%. So that's great. And at the end, if anybody wants to share their experience, that'd be awesome. Couple more seconds here. What I'll say, as y'all are finishing up this question, is that, the struggle is real, and, it'd be nice if we existed in a bubble, but COVID has impacted everything about our lives and how we do our work and what we can and can't accomplish. And so I think my overall goal here is to make sure that we're being really compassionate to ourselves as well, in that it has affected us. We're not through it yet. And so it's okay. We just acknowledge it, and we are where we are. And, the future, it will change. All right, let's wrap that up. And then we'll see in just a second here what we find. So thank you guys, those of you who wrote something in, or even if you didn't, it's okay. I want to switch right now to a little bit of how this has played out in our programs. And this is both in our individual patient care, we have a multidisciplinary clinic, and we have the MEND program. So the issue of weight stigma and a couple of examples of patients that have come up, and these are real people, but they are meant to be examples of something we've seen more and more frequently, to kind of talk through how we've been working on this as teams, the idea of weight stigma and the idea of how do we quantify and what do we call success? And so full credit here is for Dr. Haley Ringwood and Dr. Brenda Pravakar-Gippert, because these guys are the ones who pulled it all out and talked through this, I think, in a really great way initially. This kind of a BMI trajectory change is exactly what, we want. And back in the day, we used to like print these things out and like hang them above our desks as like causes for celebration. So here's a kid, who completely normalized her BMI trajectory over the course of the year. So it went from obese to overweight to normal. Elevated heart rate, amenorrhea, hair loss, syncope. She developed an eating disorder. And so, it was a real gut check, right? Of how often do we miss or even praise disordered eating in patients with larger bodies because their BMI is, quote, improving. It is what it is. And disordered eating is so much more common, and you don't know about it unless you ask. And, certainly there are not enough resources that exist out there in the overwhelming majority of communities, but we just, if you don't even think about it, then we won't ever see it, right? And so this became a very, very cautionary tale for a lot of us. And alternatively, I want to show another patient. So this is a patient who, look at that BMI trajectory over, the entire course of their childhood. A snapshot from February of 2021, BMI of 31, which is at the 98th percentile. A1C was 7.5. So this patient was diagnosed with type 2 diabetes. And, not just like, oh, just barely, or prediabetes, like diabetes. Fast forward 8 months to October, her BMI is 32. It's 98.5%. A1C, 6.1. And so what happened to this patient over the course of 8 months? She didn't lose weight. She didn't take meds. We improved her food access by connecting her to an external resource, in this case, Denver Food Rescue, and we help distribute food for them twice a week in 2 of our clinics. She participated in MEND. She was working on the healthy goals. She was, becoming more empowered around, and had more knowledge around what she wanted to work on and what she needed to work on. She got really into skateboarding. If you just look at the BMI, it looks like a failure, right? She participated with us in this intensive intervention and she gained weight. But she normalized a chronic disease that would plague her for the rest of her life just by making some changes. And so how this has then kind of pushed us is this idea of praise, and what do we praise? And, maybe we are praising the BMI, right? Maybe there is some weight change that's happening and it's important to acknowledge that, but it's certainly not the only thing. And so we've really tried to be, again, much more kind of curious and sensitive to what could be disordered eating or unhealthy habits, but also thinking more broadly about what constitutes success. So even if kids don't lose weight, if their lab improves, oh my gosh, you can't fake that. I mean, if you drop an A1C like that, you have put in the work. Adults can't do it. Your energy levels increase, your mood stabilize, you have more physical strength and ability. You sleep better, you have regular bowel movements. Some people, that's highly motivating. You feel less stress. Again, increased strength and endurance, all of these kind of physical markers, increased confidence and self-esteem and loving yourself and loving your body, just getting at all of the different ways that we can constitute success instead of holding just so deliberately to weight as the only marker of success. And we are not doing this perfectly ourselves either. It really has been something we've been trying to evolve over time. So the last thing I want to talk about quickly before we open it up is this idea of our program and where we're at, because we're not, it looks like maybe we have all our stuff together and I'm here talking to you, but it's really a constant evolution. And so our current challenges, what is our ideal post-COVID world? Because we're not there yet. I think, COVID did provide us the opportunity to do something virtual that we would have probably never tried before. I do feel like at the end of 2 years, I can strongly say that for these type of interventions, in person is better. It's magical. You have so much more community building, parents stay more engaged. But, you know, what virtual has allowed us to do is reach families who were never going to be able to make it to such an intensive intervention in person. And so, you know, could you get to an ideal future state where there is a mix of both, and people can kind of self-select into one or the other, and they can mix it up. And then you can really start to play with, how do I keep it effective, but how do I also have the kind of reach that that we need to more seriously address the problem. Fidelity, you know, are we still doing MEND? We're kind of at a place now where we're like, it's not really MEND, but it's, you know, it's structured around all those things that work. You know, we're adapting, we're being really deliberate, versus in COVID, there was nothing deliberate. It was you know, for any of you who have kids or might've seen Frozen 2, it was all about just, you know, do the next right thing. And it's not always perfect, and it's not always that fidelity that you need, but it just felt like what was possible in the moment, and what did have meaning. And measurement, you know, what should we measure as we've kind of dealt with the, you know, the BMI stuff? What should we measure moving forward? And what you measure is what you can change. And, you know, knowing how much of our stuff is still in virtual capacity, we haven't figured this out yet either. You know, the flow sheets and the questionnaires, and, you know, so we're not being as deliberate right now about measuring our impact as I think we need to be long-term. So that's just kind of an honest reckoning of what's working and what's not for us right now. And then the last thing I've got here, sorry, is what I would love to leave you all with is not like, oh, Denver Health did this thing called MEND, and that seems really nice, but it's just not going to happen in my clinic, or it's not possible in my organization, or right now. I really feel like some of what's been harmful about these guidelines is it makes it seem so complicated, and there aren't many affordable, you know, packaged programs that, you know, you can take and implement. More are coming. There is a CDC CORD project. They're in version 3.0 right now, which will wrap up, I think, end of next year, which is going to create 5 more packaged programs that, you know, healthcare can use. But there are a lot of challenges, but it's not rocket science. It really is something that, like, you could put your heads together and be like, okay, cool. Next week, we're going to talk about, you know, reading food labels, and then we're going to talk about fats, and then we're going to talk about how to do a grocery store tour. And, you know, you can build it out with the right kind of tools. So it's not rocket science, but it is hard. And COVID made everything so hard. And so there's always something, even if sometimes it's small, that can be done. And so that's what I'd love to leave y'all with now, is not a sense of like impending doom or all the things I'm not doing right or aren't possible, but, you know, just start wherever you are. And if you're excited and passionate about it, that's always the best place to be. So here's my contact information. I'd love to open it up for questions.
Okay. The first question that we have coming through, as you talk about the translational ability of taking what you do and how it may be applicable to others, do you have any tips around pitfalls to avoid?
Ooh. Yeah, you know, honestly, I think the biggest challenge is the translational, right? And it's one thing to have all these randomized controlled trials, but if you can't implement it and scale it, and when I say you, I mean like society, like, then we don't have what we need. And so I think pitfalls to avoid, I think the work, if you're going to start something like this, it's all translational. And so you have to sell it right. And that relies on ideally knowing your organization, speaking their language, and hitting them where their values are, right? So, you know, for the example of my organization, you know, leaders really care about this. They really care about our patients and our kiddos, and they really see this problem day to day. So the more we could angle it that way, right? Of like how many kids are burdened with this, how, the lab findings that, relying on data, spoke their language, and making it easy for them to say yes, right? All along the way, when we got the grant, it was like, we're going to take care. There wasn't an ask, right? It was like, we're going to take care of this. And then every chance we had, sharing the good news, until we got to a point where we did have an ask. We had built that foundation, and then we were able to say, yes, we need some money, but speaking their language, right? We had developed this like extra layer. We thought we could generate some revenue, kind of talking about the money and the numbers, and making it palatable to people, because ultimately they're responsible for keeping the lights on. So yeah, just making sure that like we don't burden, to the extent possible, we don't burden leaders with too much too fast, because then we're setting it up for being difficult to implement.
Yeah, and really that return on investment.
Definitely.
So building on that, what is something that you wish that someone told you when you were first starting?
I think, that it would be hard, but also that, there was opportunity to, make it ours on our own. It was really, really was helpful in the early days to have such a structured program. And like I briefly mentioned, I did similar work in DC, and, we created our own program, and I did everything. Like I didn't have a way to train staff. So I was the one like leading the groups and then coordinating the medical visits and doing all this stuff. And, it was really nice to have something that like I could implement, but over time, it didn't suit our needs. And so I think it took me a while to realize like it's okay to adapt in ways that empower teams and, address where our families are and what they need. I continue to feel like cooking demonstrations and culinary education is absolutely where the magic is a lot of times. And, not being afraid to kind of trust the knowledge of that we had as like a health center of what we needed.
Thank you. And we'll do one last question.
Yeah.
The components that you adapted during COVID, what are some of them that you hope to keep as you move forward?
Yeah, definitely the cooking education. And we keep doing, and the great thing about cooking education demos and stuff is like, you can get $1,000 and you're like, sweet, I can do a lot with $1,000 or $500, and so we've kind of we keep identifying little tiny pockets of money that help us to carry that forward. When we got our first cooking demo grant during the pandemic, we used it to buy a lot of the supplies. And now we have those indefinitely, little kitchen carts and induction burners and some pots and pans. So the good thing is you buy that once and then you've got it forever. So the cooking demos feel very meaningful. Again, I like the fact that some families can only do virtual. And so we get them versus otherwise, we would have just kind of thrown up our hands and said, well, it doesn't work for them. It's met a very particular need. So I'd like to keep some form of virtual going long-term too.
Thank you, Jessica, and sharing what this looks like in real life and how it can be translational to others, to ideas to take away in their own communities as they start, how they can build, and obviously the vision of where they can get based on where you all are. With that, we are at the end of time. And before anyone leaves, there are a couple important things that Jenny has for us.
So I'm going to launch our final poll with some closing and evaluation questions on telling us how we did today. Did we meet our objectives? And if you walked away with some additional knowledge. I'm also going to put into the chat the CE post-webinar survey that will also be sent out to you guys, as well as the webinar recording. The slides will be posted on our website and dispersed to everyone who registered and attended, and to also those who registered and didn't get a chance to attend. And you're welcome to share that with any of your staff members or any colleagues that this information could be pivotal to their school-based health center. We'll just give it a couple more minutes for our closing and evaluation questions. If you have any other things, you can pop them in the chat.
And I'm just reading all of the results coming in from how COVID has impacted your ability. And I mean, even just reading through that list, I mean, it's how incredibly disruptive. And again, how much of it is still ongoing. And so I totally see you and I hear you, and you all do such awesome jobs. So please, I hope it gets easier. I really, and I'm just thinking about all of you. That's where we are now.
And we are at the 12:30 mark, so we appreciate everyone for attending, and we appreciate being a part of this, asking your questions, and the contact information will be in the slides. If you have any questions, feel free to reach out to Jessica, Paula, or Shamika. Thank you.